Welcome, everyone. I'm very happy to introduce to you the fourth in our series relating to clinical pharmacy webinar, which is a growing area of professional expertise in India. I'm very happy to find that growing interest, there's a growing interest all over the country as we continue to present to you a variety of webinars capturing exciting developments in the field of healthcare. Now, it is my very proud privilege to introduce to you the iconic clinical hematologist from CMC Vellore, Dr. Chepsi Philip, who has established the Believers Church Medical College Hospital, Tiruvalla Rectum, a state-of-the-art hematology and bone marrow transplant service. One of the earliest to do his DM training in hematology from CMC Vellore, he underwent his fellowship training, that is the IACA Fellow in Bone and Marrow Transplantation from FHCRC Seattle, USA. Rectum is the acronym for Regional Advanced Center for Transplantation, Hematolympho-Oncology, and Marrow Disease. In a very short time, with limited personnel at his disposal, he has built up a program with enviable success. I welcome Dr. Chepsi to take over from me.
Thank you. Thank you, Dr. Grace, for those kind words. Now, I think our session is going to focus on our main stars for the evening. So these are us clinical pharmacists, and it is my proud privilege to actually have been working with them. This is my first experience with the specialty of clinical pharmacists. So I have never been exposed to such an expertise earlier, and I've been really honored to have them as part of our team. And one thing which is very important for all of us to know is that specialties grow with time. It is not the same prescription for success which we can follow year after year. We have to evolve with time, and that is what I'm understanding and learning with my interaction with this particular specialist who have their own niche. So they have this particular area of expertise in regarding drug management, interaction, reconciliation. Now, these are all I've never been used to a subset which can actually handle all that. So when we grow as a specialty, it is important to have specialists for every job. That is all. That is the way we will succeed. I think in the future, and I'm learning to accept that we have to integrate whatever expertise that we have and not encroach upon each other's work. It's not encroachment. It's actually developing that particular expertise. So I'm sure in as we go, and I had this exposure when I went to Seattle. I'd seen clinical pharmacists there and the role that they have played. They're a very important addition to the team. It takes off a lot of management. Actually, they can invest and put their inputs into, which will allow the rest of the team members to focus on their particular area. So the more niche areas exist, the more expertise we can deliver, and ultimately, patient is going to benefit. So this I'm very happy to be part of a growing team here. We are still growing, and Grace has given some very kind words. Now it is I'll stop with that, and I'd like to introduce a good panel of speakers that we have over here. Like I told you, this is my first exposure to this niche as such, and I've been told that we've got some excellent speakers by Grace. So we have Dr. Kirti Ji, who has already developed into hematology clinical pharmacist. So she is probably going to be one of amongst the first, I think, in this country who is dealing entirely into hematology. I'll be very curious and keen to learn from her. And I just had a brief chat with her. So she's already worked with one of my seniors from Vellore, Dr. Sachin earlier, and now she's moved on to Sparsh Hospital. And yeah, we are eagerly waiting to hear from her how further we can evolve this field into and what has been her experience so far. Also joining her in the discussions would be my colleague Anju, who works with me in hematology and is now we are now focusing on transplant for her. So we are evolving as a team. She'll share the experiences that we have in Believers Church. And then we also have Dr. Renita from Tata. So she is doing her fellowship beyond her basic clinical pharmacy degree. She's into oncotherapeutics. So the roles and responsibilities in hematology and the possibilities and potentials in future. I think it's going to be an exciting session, and I'm looking forward to hearing from all of them. So first on would be Dr. Kirti Ji.
Thank you so much for the introduction, sir, and thank you so much for having me today. It's going to be a very good opportunity for me to learn a lot of things here. And yeah, I know you have already done 3 transplants, I guess, but it is not something new. That we are going to learn today. I mean, I'm here for 4 years. I don't know what is new and what is old now. So I'll just start with my presentation. Um, uh, is my presentation visible?
Yeah, your first slide is there.
Okay. Okay. So today we are actually discussing about the roles and responsibilities of the clinical pharmacist in hematology. So I'm going to start with them. Roles and responsibilities. The first and foremost thing. So there are few things where general clinical pharmacists, the set of other departments will be doing, and we, especially as an oncology pharmacist, will be doing something little extra. And I will not say that there's too much of deviation. It's only an expertise in their own field. Okay. So patient medication history. Why is collecting patient medication history important is, see, the more details you should collect, the more better it is to treat the patient. Basically, because there are people who do not want to reveal their medication history. So, for example, there are retroviral positive patients who are newly diagnosed with AML, MDS, and stuff, who are all on retroviral therapy. Usually, they interact with a lot of medicines that we are giving. So, if we don't know their personal medication history, we cannot treat them fully. So, and while they are staying in the hospital, we might be missing to give their own medications where the viral reactivations can happen. So, we need to know the patient medication history properly. Then, drug interactions. So, drug interactions, the major drug interactions can be with, see, generally what we use when we say hematology and oncology, the major things that are chemotherapies, right? So when we are giving chemotherapies, what do happen? We have to give a anti-emetic drugs. So 5-HT3 inhibitors are the most commonly used ones. And in AML and many other MDS patients whose neutropenic, they're neutropenic. So we have to give them antifungals. When we are giving these two drugs, 5-HT3 with antifungals, there's a drug-drug interaction, and that is causing a QT prolongation, which is again another side effect, major side effect. So if we, I mean, not all 5-HT3 inhibitors have this interaction, but there's mainly ondansetron, granisetron, which has the interaction. So we might have to avoid that and use a palinosetron as an uh, other agent, which is actually good. So it's important for us to check the drug interactions. And antimicrobial stewardship, this is very important thing. Like now the microbial flora in the hospitals, most of them are drug resistant. So we have to make sure we are using the right drug on the right time for the right patient also, this, which has been a major challenge these days. And usage of colistin as a single agent is another problem because of the emerging resistance. Another thing, most of the medication error coming to that area in antimicrobial stewardship is, see, if a patient is coming C. diff positive, what do we use? What is the good choice of antibiotic? Vancomycin. Correct. So vancomycin, when we are giving vancomycin, how do you want to give? Many of them feel that rather than oral, IV can be a better choice. But if it is a C. diff diarrhea, it is always good to give an it is always preferred to give an oral vancomycin, should be given. Okay. So if you're not giving an oral vancomycin and you're giving a IV, it becomes a medication error. It is not effective drug. And what do you do in case of patients who have a peg tube or a yeah, peg tube or ventilator support? Then what do you do? How do you give a vancomycin? Vancomycin is a capsule you cannot dissolve. It is a hard soft gelatin capsule, you cannot dissolve it. So you can use a powder for solution, you can use a vancomycin injection, you can dissolve it with a sterile water, and then it can be fed through the peg tube. That is another option. Or metronidazole can be given. Okay. Then medication errors. Coming to medication errors is an expertise of clinical pharmacists mainly. So many types of errors like prescription, transcription, indenting, dispensing errors, administration errors. I'll be discussing and I will give you examples in the further slides. But our duty has a major role in medication errors. We are like a new set of eyes in the department wherever we are working. Whenever we are going through a file, we are like a new set of eyes. So everything that is going past through us, you have to make sure there is no error in it when it is passing through us. Or if there is an error, you have to intervene then and there, and you have to have the guts to tell the doctor, you're wrong, please try to correct it. Not in a rude way, definitely. You have to have that guts. And yeah, Dr. Chipsy, like there are not many doctors who would like to encourage us, because we try to find errors in their whatever prescriptions. So many of them don't want us to grow in our field, but luckily I worked with a team who are very encouraging, and looks like you are that guy too. uh, so coming to next, in medication errors, there are many other aspects that we have to consider. For example, there is melphalan, which is a myeloablative regimen we use in multiple myeloma. Okay, so what happens in melphalan? You have to. It is a what do you say? It is a drug. When you start dilution, you have to finish the dilution and the administration of the drug within 90 minutes to 100 minutes. You shouldn't let the patient go to the washroom or anything, or you should make sure patient is comfortable and everything. Then you have to go for the dilution, because the time of reconstitution has to be noted, and the many drugs like that, melphalan is one of them. Okay, so special precautions for the dilution of melphalan is required. Okay, then identifying and reporting of adverse events. We are seeing that in hemato-oncology, mainly the adverse events and adverse drug reporting is very important, because see, there are few drugs which are launched recently or anything, and we cannot see. For example, venetoclax, it is a new drug. So there are limited side effects available on internet or Medscape or Micromedics or Lexicon. In all these data, there is a limited availability of data. But when you're seeing a patient, every patient can be different, right? So there are new side effects that I observe in my own patient. The uric acid levels are increasing even after 2 weeks for there is one patient, but the tumor burden is around 20%. There's 20% of tumor burden. But the uric acid level, even with venetoclax and giving allopurinol, rasburicase, the uric acid level has been increasing even after 2 weeks. This is a new finding. I want to report it. And we shouldn't stop ourselves from reporting it. So it's better to report it, so that for the newer drugs, it's always better to do that. And for example, there's posaconazole oral tablets available now, which are gastro-resistant. So now, when you monitor trough levels for posaconazole, they only mention that it has to be more than zero point 0.7 ng per dl. But there is no specified range. There is no range like in cyclosporin toxicity, it has to be within 250 or something like that. There's no range for posaconazole, but it can be more than zero point 0.7. Is it safe for the patient? No, it isn't safe. We have experienced few patients having very unexpected side effects, and we had to reduce the dosage, which I will be going through in the further slides. And next thing, involving in continuous education programs. See, we are always behind the doctors in medication errors, patient medication history, and drug interactions and stuff. But to achieve all these goals, it's very important to run these education programs to nurses and residents. Only then, when we streamline these things, the other errors and medication errors like administration errors can be avoided by educating nurses, and prescription transcription errors can be avoided by educating residents. So this continual education programs is required. And there are sometimes I make a question paper, like every month I make a very um, question paper, small question paper, and we give an exam to the nurses, and we give them 1,000 rupees or 1,500 rupees every month. So it's an appreciation for them, just because they have done well in the exam, but it is also showing that they're interested in participating in this education program. So it is one of the initiative that we have started. Then drug formulary, yeah, I discuss with the administrators in the hospital, and also make a drug formulary and give it to the central pharmacy, so that there is no deviation and there is continuous medications available always in the hematology, whatever drugs that we are using and everything, so that there is no stockouts and all that. We have to always be in touch with the central pharmacy to make sure all the drugs are available. So I'm also a BMT coordinator for my team, and we have hired one more, but I have been a BMT coordinator too since 2 years. So I always make sure I indent the drugs for that patient before they come to the hospital and admit. Or I make sure all the conditioning drugs and the supportive medications are in the hospital before the patient comes into the hospital. We make them pay an advance money of 3 or 4 lakh, and we try to arrange all the medicines and make sure that the patient is available, because we shouldn't admit the patient for conditioning and then there is a stock out of some medications, and we don't want to go through that vicious cycle, so we do that. Then patient education. So patient education is one of the important thing. So doctors do counsel about the patient disease status and everything, but it is also a major role of clinical pharmacists to explain. See, once a patient is coming to us, these patients are suffering with an blood cancer. When you say that, they are in a different state of mind, so they need someone to explain them what is going to happen about their treatment. Okay, so they are here with us for 6 to 8 months nearly. There are several protocols. See, when, for example, they come with a B-cell ALL, their kid is diagnosed with a B-cell ALL, and they come to hospital. We say induction, we say consolidation, there's maintenance phase, but they are not in the mental state to understand all this. We have to sit with them. We have to keep the protocol with us and explain them. These are the tests that we will do. These are the medications that we will be giving to your child. These are the expected side effects. When these side effects are observed in your child, these are the medications that you have to do. And when there is febrile neutropenia, you're supposed to come to hospital before 1 hour. These kind of education has to be given to a patient attenders, that is caregivers. Otherwise, we cannot make sure that patient will report all the adverse events to us, because a chemotherapy is a very vicious thing for them, right? So they need to understand what is going on with them. So we have something called as protocols. We make SOPs and protocols for every cycle, and we give a copy to the patients, and we keep one copy with us, and we make sure they come. It's a schedule. We put dates and we give a schedule to them, and they are supposed to follow up on those intervals to us. And if any issues, they have to come in between too. And for example, there is Wincristin and Dono-Robeson today. These are the investigations that are to be done. It is mentioned on the first paper. So I will show the SOP in the further slides. I have them. Institutional policies like extravasation policy and hazardous drug spillage policies has to be put in place by clinical pharmacists, and occasional audits has to be done. Like I told that I conduct exams to the nurses, right? That is one of the audit that I do. And there are more audits that I will mention to you in the further slides. I have only 10 more minutes, is it? I have to rush up.
Yeah, it would be advisable, correct?
Okay. Oncology pharmacists ensure the safety in compounding, preparing, and dispensing the chemotherapy. And extravasation policy we have to put in place, and hazardous drug spillage policies that I mentioned in the hospital formulary, and aiding in chemotherapy order writing. So I'll tell you that in further slides. So aiding in chemotherapy order writing. So what happens is patient when they're coming, we have to make sure that the height and weight are correctly checked, because the height and weight depends on how you calculate the drug dosages. So what we do is we double check that, and then we write an order in our protocol, and that is double checked by me. Basically, I make the protocols too for all the diseases based on the risk stratification. Like from the BFM 2002, I have moduled the high risk, intermediate risk, and standard risk protocols, and we have made them into protocols. And there is a pre-printed order. We just have to fill in the oh, this is we just have to fill in the doses, so that there is no confusion, there is no prescription errors, and there is no dilemma about the handwriting, which drug it is it Dono-Robeson or is it a doxorubicin. Okay, then identifying the patient allergy status, minimizing drug wastage. So what happens is, if at all there's an AML patient, decitabine protocol, then we calculate the cumulative dosage for all the 5 days, and then if at all the patient's BSA is too high or too low, then this drug wastage minimizing will be helpful, because we can calculate the cumulative dosage and then divide accordingly. Okay, then managing the drug shortages, we have to be in contact with the central pharmacy and manage the drug shortages regularly. And decreasing the exposure to the hazardous drug and spill management and waste management has to be made by us and must focus on providing a direct patient care. Like I discussed previously about counseling the patients regularly about everything what is going on. We have to provide patient direct care and offering education to patients, the same thing. Participating in clinical decision making, like there's an LFT of the patient and we have to go through the LFT, and according to the bilirubin or SGOT, SGPT, you are supposed to suggest to the doctor saying that you're supposed to reduce the dosage of vincristin or whatever other drugs it is. Dose modifications are necessary for so and so drugs. Okay, then capturing data and case reporting. Currently, I'm collecting so many data about APML, and because APML, there are many case reports that I'm writing now, around 2 3, and there is a data that we are capturing on a larger scale. And on febrile neutropenia, there are many patients that come with febrile neutropenia basically. So we do something called as exciton test, which is a febrile neutropenia panel where we get results in around 6 to 12 hours. They give us what are the gram negative bugs and gram positive bugs, everything. But our culture report takes 48 hours to come. So we cannot solely depend on the culture. So we do this febrile neutropenia panel. I'm currently capturing the data upon that also. Then, as I mentioned, this is a repetition of previous slide only. It is understanding the pain of patients. So cancer therapies are mostly targeted and personalized therapies. So pharmacists are the key resources in educating and managing the adverse events and toxicities of the treatment, while emphasizing the importance of the medication and medication adherence to the patient and providing supportive care. So basically, many patients who come from the rural background or anything, they don't know about how to take the medications. So we have to make sure to tell them. So what I personally do is I give them a notebooks to all of the patients and make sure I write the dates for the mainly 6-MP, 6-mercaptopurine and steroids, which are induction therapy drugs. So we write them in the books and make sure they take it every day and tick their date column, and they take it every day. And whenever they visit the hospital, I make sure I see the book and I sign off there. And it is also important for the medication adherence, because when they adhere to that, the compliance, the relapse rates and everything, and the end of induction MRD depends upon their adherence of the medication. So that is one important thing that I follow. And reduction of medication errors, how is it possible? Like I mentioned, pre-printed medication orders and standard protocols, if you put them in place for every disease, and along with risk stratification. For example, in a very older age people in DLBCL, you cannot give R-CHOP completely, because of their age they cannot tolerate it. So you might have to give RCVP protocol. So when you categorize that this is above 60, above this is above 40 years, you can categorize that and make a protocol for it and keep it. It's a readily available in the system. You all you have to do is take a printout and fill the protocol and give. You need not put it in the drug chart, and there's a confusion. So there's like 30 minutes before you have to give a pre-medication. They almost forget to give pre-medication, directly start with the chemotherapy. Sometimes it is possible, medication error, anyhow it is possible. So we have to try to avoid all those things. So when there's a pre-printed order, I feel it is easier. Electronic applications for the management and data capturing, and Tolman lettering for LASA drugs. So this has personally, I mean, this has happened in my hospital. Even though there was Tolman lettering and everything, there is always confusion about this sound alike and look alike drugs like epirubicin, doxorubicin, daunorubicin. This can also be, we indent the drugs, but when there is a miscommunication with the pharmacy and the nursing staff while indenting, that can still happen. But Tolman lettering is one of the recommended thing for LASA drugs. Then second pair of eyes, I mentioned that we are the second pair of eyes. We have to make sure that none of this is happening. This is our pre-printed order. It is a myeloma protocol, bortezomib, lenalidomide, dexamethasone regimen. So here we have mentioned when the patient comes in, baseline, what all investigations to be done, once in 4 weeks, what to be done, during maintenance, what to be done, and so the body surface area, we put it like this, including the formula. They have to write there, and 2 nurses would be signing there. And there's a prescriber signature below. On every page, the doctors have to sign. Okay, then there is this pre-medications are not required for the bortezomib therapy, and the medication outline is there. And those modifications are also mentioned in the protocols, so that we need not again go to the BC Cancer Agency or go through other protocols and check out, does this drug need dose modification if patient has diarrhea, peripheral neuropathy, or liver dose adjustments. So everything will be there in the protocol. All you have to do is fill and make sure patient is satisfying the criteria for the protocol and give out the protocol. And this is how we do. And this doctor signature given by nurses and pharmacist signature. Pharmacists in my department, every medication order must be signed off by a clinical pharmacist, and every drug that we receive into the ward will be cross-checked by the clinical pharmacist, and bedside rounds also will be done usually. And there are some medication errors that has happened. I have put them as a scenario: medication error, drug interactions, and everything. I'll go through them very fast. uh, a 45-year-old female complaint, known case of aplastic anemia, presented to the hospital with convulsions. So, what is the drugs she is on? Cyclosporin, posaconazole, Revolade, Septrandius, and valacyclovir. So, what is the reason for convulsion? Cyclosporin, when the levels are too high and they're not monitored, or even when monitored with posaconazole, what happens is the levels shoot up. So, whenever you're giving cyclosporin and posaconazole together, cyclosporin level has to be reduced by 50%, or else there can be unexpected side effect like press syndrome and others, which will be causing convulsions. So therapeutic drug monitoring is one of the thing that we have to do. Okay, second case, a patient 40-year-old newly diagnosed with ITP with a platelet count of I cannot see this side, 1 second, a platelet count of 4K, and was started on dexamethasone 40 mg 4 days, and the platelet on day 4 developed to 7K. But then patient was started on Revolut 50 mg, platelet was increased to 45K, and LFTs were normal. In the period of 2 weeks, when the patient came back, the platelet was 45. So just to optimize the drug dosage of Revolut, we increased it to 75 mg and advised for weekly CBC. In the meantime, patient had visited orthopedician for the knee pain and was initiated on the treatment. The history was not initially taken, but on the follow-up, patient had dropped the platelet to 20K. So we tried to rule out other causes, what were the other things, but the patient was ITP. There was no other cause. What is the reason for platelet drop? Patient was actually started on calcium supplements when he visited orthopedician. So calcium and Revolade has a drug interaction. Revolade is nothing but an TPO agonist. It is an L-thrombopag, which is helped in increasing the platelets. So the platelet drop was because of the drug interaction. So at least minimum 4 hours gap between the calcium supplements or milk and curd products has to be given, at least 4 hours of gap. The same thing. Then 2-year-old baby was diagnosed with iron deficiency anemia and was started on oral iron supplements. The same thing, patient was fed milk after the iron supplements, oral iron therapy. That is the reason why patient was not coming out of the iron deficiency anemia. So many of the drugs have drug interact. I mean, milk and drug interaction. So we are not supposed to immediately feed milk. At least 4 hours gap should be given. Then case 4, there's this B cell ALL patient on BFM 2002 induction 1B protocol, was started on 6MP 50 mg per m square. The patient's BSA was 1.2. But patient was initially, when we are giving a myelosuppressive drug, we always try to start with half the dose so that we don't let the patient go into severe myelosuppression. But even with starting half the dose, what happened was the cytopenias for this child persisted for more than 2 weeks. Then we tried to send to this TPMT and NUDT 15 mutations. So there was this homozygous deficiency for this patient. So when there's homozygous deficiency, you have to give this mercaptopurine for maybe 10% of the dose or less than 10%. So this kid is actually now into maintenance, and we are giving only twice a week of 6MP 50 mg, Monday and Thursday. That's it. And his cytopenias are not there anymore, and he's at good WBC count. If a heterozygous must reduce based on tolerability, there is no fixed dosage for that, but just based on the cytopenias, you have to adjust. Then 25-year-old male patient admitted with relapsed Hodgkin's lymphoma was started with ICE protocol. I made this protocol and I made this mistake. I will tell you what it is. So this ICE regimen is a highly hematogenic potential regimen because ICE is nothing but ifosfamide and stuff, adiposide. So we used a high hematogenic regimen as per BCCA and NCCN guidelines, where we use NK1 analog, which is fosaprepitant. So aprepitant and ifosfamide have a drug interaction where it increases the ifosfamide neurotoxicity. So this patient had encephalopathy, and we had to treat him with methylene blue. So we had to be the set of eyes, but I became a toxic thing for this patient. So methylene blue treated this patient later. I'll skip this. It's not very important. I guess we're running out of time. Okay.
Yeah, okay, we can have the closing slide.
Yeah.
Summarize. Yeah, thanks.
Oh, that's it. There are like many things. I do audits on chemotherapy dilution, errors, and restricted antibiotics, and I conduct CNE exams and protocol. We have to follow the protocols. If there is any deviation, there will be a lot of errors. That's why this is my team: Dr. Mahesh and Dr. Sunil, Dr. Anand, and these are fellows. And I couldn't put the nurses' pictures. That's it. Thank you.
Thank you. Thank you, Kirti. You've been very lucid in your explanation, and I can see that you worked around for a while because you're quite comfortable handling all whatever you explain. So there are some really specific questions that have come in. I think I will. One is regarding IV vancomycin error. So the question is, what can we do if there is a vancomycin error? And second part of the question is, can you explain the dilution of IV voriconazole for oral administration? That is one question.
Voriconazole?
For oral administrations. That is one of.
So
Then the
it's
second.
vancomycin. So basically, vancomycin, when given by IV, it is not active for C. diff diarrhea. So it is always preferable to use a oral vancomycin capsules. Yeah, when there was a time recently when oral vancomycin capsules were not available, so we use metronidazole. But if there's a patient with drug resistance for metronidazole, then you have to use vancomycin only. Or patient is having a peg feed, then you have to give only vancomycin. Then what is the option? So you basically 125 mg Q6H is the dosage of vancomycin. So you have to take a vancomycin injection, powder for injection, which is available. You have to dilute it with the sterile water for injection, and you can feed that to the patient in 4 divided doses. And what that one vial comes in 1 gram, and you can give it for 24 hours. You have to use it within 24 hours. That is the dilution for the vancomycin. And once the error has occurred, there is nothing to manage about it. Only thing is you have to switch on from IV to oral. That is the only option available.
Okay, another question that has come in is why did you specify that within an hour the patient has to reach in case of febrile neutropenia? You made a statement.
I made a statement. Yes, I think you can answer that better than me, sir. That's how my doctors have guided me. Yeah, febrile neutropenia can lead to sepsis because they are neutropenic patients, right? So their immunity is zero. Their neutrophils are zero almost. So when there is a neutropenia, they can go to sepsis. And we have personally seen this patient. You are supposed to start an antibiotic, broad spectrum antibiotic within 1 hour to half an hour, because the delay you make in that will change the whole scenario for the patient can go on ventilator, and patient can lose their life too if they are delayed.
Yeah, that's a very important point that you made, Kirti. So febrile neutropenia, like you said, is when you have neutropenia with a fever more than 100.4, which lasts for more than an hour. And what evidence has shown us is that you have a golden hour in that first 1 hour. In that 1 hour of the antibiotic, it is not just giving the antibiotic, it is about giving the most appropriate antibiotic. And if you miss that time, it's a 50% mortality. That means 2 out of 1 is not going to make it. So that is something which is entirely in our hands. Like if you have a good policy and good protocol, that is something every hematologist is going to be very finicky and upset if you delay that. That is
Yeah.
going to be one of the you will not like the hematologist when he sees the febrile neutropenia part of it. That is one. The another question that came in was relating to what is hematology. So I'll just broadly tell you about hematology, because that is a science and study of blood cancer and blood diseases. So broadly, we say any disease that affects the bone, blood, and marrow, that comes under hematological diseases. So like how Kirti went through all her slides, we deal with blood cancers like ALL, the acute lymphoblastic leukemia. Leukemia, lymphoma, and myeloma are the most commonest blood cancers, which is specifically focused and treated by clinical hematologist if you have one. And then you have non-malignant diseases. Primarily, you have bleeding disorders like hemophilia. You can have bone marrow failure syndromes like aplastic anemias, thrombocytopenia, ITP, all sorts of anemia. So the hematology is the science which is focused on care of both malignant and non-malignant diseases. And most hematologists at most centers also do the stem cell transplantation as part of their expertise. So the field is still growing. Now there are probably 100 centers now all over the country which has focused hematology expertise. But gradually the public will know more once the numbers increase. So I think the rest of the questions, I think I'll come after Anju's is also over, because that might be common questions. Thank you. Thank you, Kirti, so much. Thanks. So next speaker is going to be my colleague, Dr. Anju Estepan, who works with me at Believers. So she is also, she's probably 3-4 years down the line what Kirti is already doing. But we've just started our transplant program, and our roles are a little bit more, probably more different, because we've given them a little more clinical freedom to in managing their patients. So I think that there is no boundaries as to what can be done, what cannot be done. It depends on your center and the leverage that your center gives it to you. But it all goes under supervision. But I think there is a bit more clinical leverage in our experience here. I think I'll hand it over to Anju, who's been one of our most brilliant clinical pharmacists who is working with us. She joined here for her first hands-on work. She trained in Bangalore, and I think I'll hand it over further to Anju to take it from here. Anju, over to you now.
Thank you so much, sir. Hi, everyone. I'm Dr. Anju Estepan, and I'm so happy to be a part of this discussion. So I will directly go to the presentation. Our focus today will be the role of clinical pharmacist in bone marrow transplant, and I will also share our experience in Believers Church Medical College Hospital. So broadly, these are our learning objective: the what, when, and how of a bone marrow transplant, and most importantly, the roles and responsibilities of a clinical pharmacist. So let's begin with what is a bone marrow transplant. Normally, everybody thinks that bone marrow transplant involves invasive surgery. That is because in solid organs like lung, liver, or kidney transplant, it requires surgery and general anesthesia in an operation theater. But a bone marrow transplant does not involve surgery. So, what exactly happens in a bone marrow transplant? It involves the collection of stem cells from patient or healthy donors, peripheral blood or bone marrow, and preserved. Then the patient bone marrow will be destroyed by chemotherapy, and the collected stem cells will be returned or infused back to patient bloodstream like a normal blood transfusion. So why do people think that it's a surgery, or why a bone marrow transplant is known as why a stem cell transplant is known as bone marrow transplant? That is because in the beginning or in the past, when the bone marrow transplant was first done in 1980s, the stem cells were collected from the bone marrow of the pelvic bone, which require the donor to be under anesthesia. That's how the name bone marrow transplant got stuck. But nowadays, we don't have to collect the stem cells from the bone marrow. It is like a blood transfusion in which the stem cells will be collected from the peripheral blood by apheresis, and the collected stem cells will be returned back to the patient bloodstream. So coming to the types of bone marrow transplant, there are mainly three types: autologous, allogenic, and syngeneic. In autologous, we use patient's own stem cells, whereas in allogenic, we collect stem cells from a related or unrelated donor. And in syngeneic, we use stem cells of an identical twin. When do we perform a bone marrow transplant? Bone marrow transplant is a life-saving procedure which has been scientifically proven as curative in a broad variety of diseases. Based on high-quality evidence, there are now clear indications for a bone marrow transplant from American Society of Blood and Marrow Transplantation. To summarize, the indications generally involve hematological diseases, cancers like acute myeloid leukemia, acute lymphoblastic leukemia, chronic myeloid leukemia, and some solid tumors like germ cell tumor. Bone marrow transplant is a highly technical process, require a multidisciplinary team. We, the clinical pharmacists, are an integral members of this team. The roles of a clinical pharmacist are now well defined and established in the West, as laid out by the different societies like ASBMT, PACJZ, and EBMT. As an outline, our roles focus upon medication management and monitoring, patient care, transition planning, education, and research and quality improvement. To make it easier to understand, I will share my experience in Believers Church Medical College Hospital as a clinical pharmacist. A stem cell transplant or a bone marrow transplant have multiple phases. As you can see here, these are the different phases. And the planning is required before, during, and after the transplant, which I will be detailing as follows. So the first phase is patient selection and evaluation. When a patient is selected for a bone marrow transplant, the indications and protocols are detailed through a literature search. For example, the allogenic transplant for a patient with high-risk ALL and autologous transplant for multiple myeloma was refined through adequate literature search. This is to ensure that we are giving the right treatment to the right patient. Following confirmation, we then detail the exact nature of treatment to the patient with our consenting process. This is an example of our consent. Once the patient agrees, then the workup begins. This is to check whether the patient is fit for the procedure or not. It includes various blood investigations and clearance from various departments. This is an example of a workup. Next is donor selection and evaluation. This is another crucial phase to ensure the most compatible donor with the recipient. We determine whether the donor is compatible or not by looking at the HLA. HLA stands for human leukocyte antigen. The best match is 10 out of 10, and we even use a half match, that is haploidentical, as donor. We usually look for the 5 loci of HLA, that is A, B, C, DRB1 and DQB1. Similarly, we detail the exact treatment process to the donor with the consenting, including harvest, apheresis machine, femoral catheter insertion, and complications to the donor. This is an example of a donor consent. This is our first donor, Divish. Next is mobilization. It is a method of stimulating hematopoietic stem cells that originate in the bone marrow to increase in number and move into the peripheral blood. We use granulocyte colony stimulating factor injection given as subcutaneous for 5 days. The most common ADR of GCSF is muscle or bone pain and headache. I suggest analgesics for the pain. Our donor Divish had complaints of back pain during the mobilization, needing paracetamol. It is also my role to assist in prepare the protocol for the donor and patient. This is an example of donor protocol. Next is harvest. We have so far used peripheral blood to apheresis the stem cells. Apheresis is the processing of whole blood into its separate components so that one particular component can be collected and stored. The main complication occurred during apheresis is hypocalcemia due to the anticoagulant citrate, which we manage with IV or oral calcium supplement. As a clinical pharmacist, I have an important role in coordinating various phases. I follow the ionized calcium values and plan calcium supplementation. In our latest apheresis, our donor had hypocalcemia during apheresis with clinical symptoms which needed an IV calcium supplement. Apheresis also require adequate access. As a policy, we use femoral access. As I said, transplant is a multidisciplinary effort. Our colleagues in transfusion medicine are a major support with apheresis and blood products. Our nephro colleagues are integral to our access. This is our nephrologist, Dr. Gio, securing the femoral access to the patient for the apheresis. Coming to conditioning phase, this is an administration of chemotherapy, radiotherapy, and/or immunotherapy to the recipient to eradicate the disease. This is done to achieve the goals of disease eradication, space creation in the bone marrow for donor stem cells, and immunosuppression to avoid graft rejection. Broadly, conditioning regimens are divided as myeloablative, reduced intensity, and non-myeloablative, as you see here. The role of clinical pharmacist in conditioning regimen are as follows. For selecting a regimen, we need to go through literature search for ensuring that we have selected the best possible regimen for our patient, considering various factors. Obtaining and assessing the medical history of the patient is very important. For example, pre-existing organ disorders that may have an effect on the PK/PD parameters of the regimen or could be contraindicated for some treatment. Drug interactions are not only relevant for conditioning but also throughout the peri-transplant period, as many of these drugs have a narrow therapeutic index with the potential to cause serious adverse events. Example, in our protocol, I ensured that since methotrexate and proton pump inhibitor have a major interaction, and I advise on the use of it. Also, other interactions need to be cross-checked to ensure patient safety and utility. Pharmacy stability. It's our prime role to ensure adequate stock of all necessary drugs in relation to transplant is maintained throughout the period, even before admitting the patient. In our case, we had to contemplate between various regimens for ALL, and after opinions and literature search, we selected out busulfan and cyclophosphamide. This is an example of conditioning regimen protocol which I prepared. Here we are conditioning for our autologous patient with melphalan. This is a myeloablative conditioning. You can see the nurse with ice chips, which will help his mucositis as a cryotherapy. Melphalan solution has a limited stability. It is important that we prepare it and not keep it stored. At our center, we prepare the melphalan and give it to the physician to administer 1 vial at a time. I also coordinate with a dietitian to flavor the ice cubes to make it more palatable. Next is transplant phase. Here we are infusing the corrected stem cells to the patient like a blood transfusion. Like I said, there is no surgery involved. The nurse cross-checking the stem cells back, and I ensure that there is no other drugs going during the transfusion, and keep a track of patient parameters. This is the part we all love. We believe that transplant is a second birth given to the patient, and we celebrate the transplant day as their birthday, giving birthday cards. Coming to the complications of hematopoietic stem cell transplant, the recovery starts from day 0 onwards, but it is also the time for potential complications. Traditionally, complications are divided as early and late. These are the most common complications seen. So far, we have seen all our patients experiencing neutropenia, thrombocytopenia, and mucositis. And it is important that we as clinical pharmacists monitor such activities to help direct the supportive care. Next common serious complication is infection. Transplant patients are significantly at risk to getting infections because of immunosuppression. In the pre-engraftment period following conditioning, there is a profound myelosuppression of 1 to 3 weeks until engraftment occurs. During this early period, gram-positive and gram-negative bacterial infections, Aspergillus and Candida fungal infections, herpes simplex viral infections are more common. As you can see here, these are the other infections which occurs. We practice strict aseptic prophylaxis and hygiene protocols. To prevent Aspergillus and Candida, we keep the patient in a HEPA filter room with positive pressure. Acyclovir as prophylaxis for herpes and Septran for pneumocystis. Because the patients undergoing hematopoietic stem cell transplant are often neutropenic for several weeks, as a transplant pharmacist, we can aid in antimicrobial selection for prophylaxis of viral, fungal, and bacterial infections, given the multitude of factors to be considered, including patient and transplant-specific risk factors, institutional formulary restrictions, and cost. When a transplant patient develops febrile neutropenia, it's our role to assist with selection of initial and subsequent antimicrobial therapies based on population risk parameters and institutional resistance pattern. Beyond optimizing individual treatment plans, we are uniquely fit to be antimicrobial stewards, as ensuring appropriate antimicrobial utilization is critical to minimizing development of resistance and improving patient outcomes. Therapeutic drug monitoring. Medications which require therapeutic drug monitoring for narrow therapeutic margin are routinely given to transplant patients. Example, busulfan and cyclosporin. Antimicrobials such as vancomycin and aminoglycosides. Antifungal agents like posaconazole and voriconazole. We as transplant pharmacists play a vital role in guiding the process and procedures for monitoring and interpretation of the pharmacokinetic parameters associated with efficacy and toxicity. Next common complication is GVHD. This is a serious and potentially life-threatening complication. With conditioning, the host tissue will get affected like liver, bowel, and skin. This activates the antigen-presenting cell, which interact with donor T cell, further aggravate attacks on host tissues as it is from another body, which leads to graft versus host disease. Graft versus host disease usually affects skin, gut, and liver, present as skin rashes, diarrhea, nausea, vomiting, or abdominal pain, raised bilirubin or raised LP. For prophylaxis in GVHD, we give cyclosporin and tacrolimus with methotrexate or MMR. And for treatment, the first line is corticosteroids. Next is transition of care. We as clinical pharmacists perform a vital role in the transition of care of the transplant patient. Critical transition can occur at admission and discharge from the hospital, during escalation or de-escalation of care to and from intensive care units. We as pharmacists are integral as to support in completing admission and discharge medication reconciliations. When transplant patients are transferred to critical care setting, the team is not familiar with the specific needs and goals for the transplant patient. The clinical pharmacist must collaborate closely with the intensive care team to ensure understanding of therapy rationale and goals that may be specific to transplant care and required laboratory monitoring. Next is patient education. Another of our central role is medication-related education, counseling patients on dosing schedules, administration instructions, and side effects is critical, as these are all items impacting patient adherence. While non-adherence is a multifactorial problem, we as pharmacists are trained to address patient understanding for administration instructions, side effect management, serious complications that warrant emergent care or follow-up. We should provide patient with strategy to improve adherence, such as use of pill box, setting reminders, and establishing a medicine routine. To summarize, we clinical pharmacists have an integral role in transplant, like admitting the patient and discharging the patient, patient education, literature search, and TDM, which I have tried to incorporate in one slide. So I should thank Dr. Chepsi, the program director of Rectum, for giving an opportunity to work as a clinical pharmacist in bone marrow transplant unit. And thank you so much, sir. And I should also thank our chairman, Dr. George Chandy, for all encouragement, and our HOD of clinical pharmacy department, that is Dr. Grace, for giving me an opportunity to be a part of this webinar. Thank you all.
Thank you, Anju. So that was again very well done, and as usual, brilliant as usual. I think I'll skip the questions now. There are 2-3 focus questions, but I think we're running out of time. I'll move on to the next speaker, Dr. Renita. So Dr. Renita has moved on from the clinical pharmacy to further advanced fellowship in a course at Tata, and I've heard great things from their program director there, who had worked in Bangalore earlier, from whom we got connected to Renita. So we are looking eagerly to hear about the opportunities beyond the clinics. And Renita has completed her basic training from JSS, and we've some good, excellent graduates from there here too. And I think I'll hand it over to Renita to take it from here. Hi, Renita. I think you can take on. Yeah.
Yes, sir. Thank you so much, sir, for your introduction and for also having me. I feel really privileged to share my perspective of the fellowship so far. Even though it's hardly been 3 months, I would love to share my perspective because it was not so long ago. I was on the other side and I was so fascinated with this opportunity. And I just hope that through my presentation, if I could reach out and kind of give a message to all those budding pharmacy graduates, I think that would be nothing like it. So this fellowship in oncotherapeutics is basically a 1-year fellowship with co-clinical pharmacology activities within oncology, but not just limited to oncology. Before I dive into the fellowship, this is what we do at the Department of Clinical Pharmacology at our center at ACTREC Tata Memorial Center. So self-explanatory as our mission is, within drug development, I'd however like to say that we work on all phases of clinical trials, but we specialize in phase 1 clinical trials, and we have a phase 1 clinical trial unit attached to our center. This fellowship was instituted under education and training mission of our department. We also have a lot of preclinical studies where we use animal models, and some of them have also translated onto the clinical side. Now, when we look at this fellowship, the whole aim of this oncotherapeutics fellowship was to ensure that individuals have a specialized level of understanding of clinical pharmacology. Now, very broadly speaking, we work on a lot of projects and a lot of studies ranging in pharmacometrics, pharmacogenomics, clinical trial methodologies, and biostatistics. The best part about this fellowship is it is very fluid. There's no set curriculum. So suppose if we had our previous fellows who were interested in clinical research, and today they've gone on to become medical advisors and heading clinical research there. We've also had a fellow who is very interested in pharmacokinetics. So this fellowship is very fluid. If you are particularly interested in some area, it allows you to specialize completely in that area. And when you're looking at all of these different categories as a fellow, right from the inception of a given project or study to overlooking all of its logistics, supporting it, ensuring everything is in place, to the completion of the study, right into medical writing and writing of publications, a fellow has to oversee and do all of these things within these given areas. Now, for the eligibility criteria of this fellowship, we have MDs in pharmacology or PharmDs, and there is 1 seat available per year, the opening of which is about in June. And there are 3 stages of application. So the first is you have a set of information that will be required by a certain date. The next phase would be a written MCQ test. And the third phase would be the interview phase. So I would like to explain, these are certain areas, key areas where we work I work within my fellowship related to hematology oncology. I'll try to summarize, there are things we do even beyond the scope of all of this, but I'll try to summarize with examples so it's easy for everybody to understand the nature of work we perform here. So within hematology oncology, these are the different categories I've broadly classified into. Before we start the therapeutic drug monitoring of any drugs or medication within our center, we look for the need for TDM for that particular drug. We look for guidelines and recommendations for the same. So when there are, what we generally refer to are the IATDM-CT guidelines. And so the 3 drugs that we are currently in hemato-oncology performing TDM for is namely voriconazole, posaconazole, and mycophenolate mofetil. So this is our TDM strategy for voriconazole. We start off the patient with 400 mg twice daily, and it's a 30-day regimen. From day 2, it's decreased to 200 mg. And then on, we do a TDM from day 5 to day 7. And since the therapeutic range of voriconazole is between 1 to 6 microgram per ml, again, based on the graph, you see if it's lesser than 1 microgram per ml, there's dose increment and a repeat TDM based on the physician and clinical pharmacologist discretion. And the same goes on for if it's greater than 6 microgram per ml. So basically, we try to keep the patient within this range to ensure there's no suboptimal level or no risk of toxicities. And once that is sorted, we then continue with the same dose, and then we introduce steroids or cyclosporin A. Very interestingly, in clinical practice, we have observed that after the first set of TDM that we had done, we observed that the risk of the breakthrough fungal infections were decreased from 10% to 3% just after 1 set of TDM that was done. So that was very interesting that we saw with voriconazole. Speaking of posaconazole, we start off with the standard dose of 200 mg thrice daily. And rightly, as Dr. Kirti mentioned, there is no range for posaconazole. So then again, it depends on the treating physician's discretion. based on a particular patient, because there's inter-individual variability. Every patient is different. So if there are lesser than 0.7, we look for increasing the frequency to 4 times a day, and then again repeat TDM to see what are the levels. So we ensure that the levels are not toxic. At the same time, the patient benefits with the effectiveness. Something very interesting about the posaconazole study that we have done at our center is, if you look closely, if you pay attention to this table, you see with patients having mucositis, they did not achieve the target level. Patients with vomiting did not achieve target levels of posaconazole. Patients with diarrhea did not achieve target levels. So this is very important for a clinical pharmacist or a clinical pharmacologist, because as important it is to kind of do a TDM for patients, it's even more important to kind of the next time identify, okay, if the patient comes with mucositis or vomiting or diarrhea, I should be aware that they will not reach the target level somehow. Similarly, what we also observed while doing a study is, if a patient was on metoclopramide or antacids or pantoprazole, you see they have not achieved that target level. So as important as doing a TDM would be, it's also important that right now we are able to kind of identify that, okay, there are these patients with side effects or patients with these medications, and we are more aware. And then we do a constant monitoring to ensure that therapy is optimized for these patients. Next, speaking of mycophenolate mofetil, now as opposed to voriconazole and posaconazole, mycophenolate mofetil had no straight up recommendations for their TDM. So we did a study to kind of establish that TDM procedure. We recruited about 48 patients at our center. And since now the threshold that we were aiming for was an AUC of 30, and interestingly, we found out that if you look at the graph carefully, you see that the patients the patients having lesser than an AUC of 19 were at a greater risk of developing graft versus host disease, as we found out the odds ratio. To be precise, 2.63 times more the risk. So this study helped us identify that, okay, it is perhaps essential, it is important that they reach a threshold, especially when you're looking in allogenic stem cell transplant patients. When we're looking at solid tumors, the threshold may be 30. But in this case that we observed, we found that if patients do not reach that AUC of 19, they are at a greater risk of developing GVHD. And so right now we are validating this method, we do regular TDM for mycophenolate mofetil, and we're waiting to collate the results and then do a thorough analysis and find out if this is valid or not. Next is, we've also worked on something very interesting. Now, we have compared 9 generic brands of asparaginase with the innovator. What we found was appalling, because we found that many of these brands did not reach the level, and what reached the required level. Like, if you notice very carefully, if you look at the innovator level there, it was about 700 international units per liter, the topmost column, and then every other else, they do not really have that kind of level. So it's very important for us as kind of clinical pharmacists and clinical pharmacologists to make sure that, especially when you're looking at curative intent in patients, that the kind of brand you use, the kind of drug you use has a kind of impact. Sometimes it's not the patient, sometimes it's not the disease, it could also be the medication you're using in those patients. So we would also encourage every other center to do a quality of generic study to understand and to be confident if this particular generic will give you that right efficacy and right safety that you're looking for in the patient. So, and I'd also like to say, because of paucity of time, I haven't put that in onto my presentation, but we happened to do a rituximab study in B-cell leukemia. However, there we found that all of the brands that we tested had comparable efficacy and safety. So it's not that every other generic brand would be suboptimal and things like that, but it's very important that we think that we run a quality testing as is available, and that is the core of what we do in clinical pharmacology as a clinical pharmacist. So that is where a clinical pharmacist would really, their acumen would really help in clinical practice, is what I believe. Then we're also looking at pharmacokinetics-driven optimization. When we look at it, we see liquid formulations in pediatrics to be a little untapped area. And so what we see here is we had simulated such a beautiful graph to back our data. So we've done in vitro studies for 6-mercaptopurine liquid formulations. We have powder for oral suspensions that we want to use of 6-mercaptopurine in pediatric patients. This is a graph that we had simulated using the GastroPlus software. So this has given us a lot more confidence to get into the bioequivalence study and then get marketing approval for this formulation. So this is the beauty of pharmacometrics, again, where a clinical pharmacologist or pharmacist would shine in. And yeah, so I just wanted to put this there because this is the kind of work that we're doing in developing 6-MP liquid formulations for pediatric patients. Looking at pharmacogenetics, so TPMT is a very important enzyme for 6-MP dosing, because if there's absence of for whatever reason, there would be a polymorphism within the the TPMT enzyme, and that results, if it's absent in a particular patient, you'll have toxicities with 6-MP. So here's what we did. We did a study within 100 patients. And as you notice the 13.3 value here, we realized that if the value goes below 13.3 of TPMT in a given patient, they're bound to have these kind of toxicities. And then because there's interruption of dosing that we see because of these toxicities. So we constantly even measure this TPMT level before we administer 6-MP for individualized dosing, as precision medicine, as we call it. So based on the level of activity of the enzyme, we then alter doses. Dr. Kirti rightly mentioned, if there would be a homozygous form of polymorphism, we stick to 10% of the dose. Or if it's heterogeneous, then based on how a patient can tolerate, that dose is then initiated for the patient. So similar to these lines, this is a very interesting case report that was published. We noticed that, again, to the lines of TPMT and 6-mercaptopurine, we saw that one patient had come in with a lot of toxicities, and we assumed that the patient would definitely lack TPMT. But it so happened that they didn't. And then this is where what I thought is, even with the right tools, the high-end, I think, state-of-art facilities, what's most important in practice is conversation with the patient. It's only after conversing with the patient that we realize, okay, this patient may have NUDT 15 polymorphism, which did happen in this case. And this was an interesting case report, since clinical pharmacists also do a lot of pharmacovigilance work. I wanted to put it out there to kind of define the same. And this is the kind of work we do as well at our center. Now, something very striking about this fellowship is the chance to work with geriatric clinic. This is something very close to my heart. So this is our team of an interdisciplinary dynamic team, I would say, of medical oncologists, clinical pharmacologists. We have physiotherapists all working. What we do within the geriatric clinic is we see older cancer patients greater than the age of 60, and we do a thorough, complete geriatric assessment. And the kind of difference and impact it makes of the life is unbelievable. This experience is very gratifying, and we would like to I don't know if anybody is, I hope, is kind of inspired by this. We really hope there are more such clinics, because we enjoy spending time with those patients and the happiness that they get sharing anything, and that benefits our decision making as well. So this is something that I really wanted to share with everyone, what we do within the fellowship, and my favorite part of the fellowship, I would say. And yeah, so when we've looked at all of the amazing work that we've done, we have a very vibrant team. This is the team of clinical pharmacology there. I would fail in my duty if I do not thank our amazing head, Dr. Vikram Gota, and our amazing, we have a clinical pharmacologist and scientific officer, Dr. Manjunath. The two of them have been instrumental in kind of developing this fellowship. And I speak for all of us in the department when I say we are blessed eternally to be under their guidance. They help us grow and learn each day. So thank you, and there's gratitude to them. We also at the department would like to acknowledge Dr. Naveen Khatri, Dr. Shripad Banavli, and Dr. Manju Singhar for collaborating with us on all of those projects. And thank you for your patient listening. If anyone has any questions, I'd be more than willing to answer them.
Thank you, Renita. Your passion just shines through your presentation. That is really great to hear from you. And Dr. Vikram had high words to say about you when we first contacted him. So congratulations on your fellowship. I think there are a lot of questions regarding fellowship. But prior to that, I'll focus a question on to Anju. Anju, are you around? So this relates to melphalan dilution. So there's a question as to, have you ever seen any contamination? So I think this is again relates to what Renita was showing in one of her generics versus innovator things. So I think these are problems which we actually face, and it's a good way to actually quantify what you're seeing, what are your doubts, and then having evidence to direct our practice further. Like that's brilliantly shown with the L-asparagines data by Renita, which she showed earlier. So similar to that, we've also seen a lot of contaminants depending on the brand. So we don't have evidence for that, but sharing our information with colleagues, now we switch on to particular brands in which we don't see it. But I'm sure if we do studies like on like that on the elastogenesis, it's going to end out with those kind of results. But then we're all students of science. We need evidence to believe what we are saying. So we leave it to more other fellows to do that and let us know what is the levels. Okay. Next question is: are there any particular guidance books to refer for oncotherapeutics? That is one of the questions. And any center that you would recommend for intern? This question is to open to all, to Kirti, Anju, and Renita. Any center that you would direct your colleagues who are now interns or who have just finished PharmD to join so that they can grow as a CP if they want to practice in India. Options in India, options abroad, and good centers where they can grow academically. Uh, Renita, you want to go first?
Okay.
Um,
Okay, Dr. Keith, you may please.
That's all right, actually.
Hmm.
So actually, Fortis Hospital in the Bangalore is one of the largest clinical pharmacy team. Actually, I know you guys have 40 clinical pharmacists, but they have an academic program. There are a lot of clinical fellow. I mean, there are a lot of interns after passing out. They come and they learn. So they have a beautiful, structured, mannered. Training for clinical interns, clinical pharmacy interns who are coming. So I would recommend Fortis Hospital.
Okay. Renita, anything from your end?
Yes, sir. So within my internship, I happened to intern with the Tata Memorial Hospital in oncology, and that is where my interest and love for oncology kind of grew. So I would say it is best when you're looking at internships, it is important to see what specialization you want to choose, and then choose a center which would provide great resources in that specialization. If you're looking at oncology, I would definitely recommend the Tata Memorial Hospital. If you're looking at basic clinical pharmacology as well, we have our center doing great. Similarly, I'm pretty sure that there would be other such centers. I don't know of because I have not had personal experience with other specializations, but I would say if you're looking at a certain particular specialization, then choose a center which would provide you that kind of backing and resources in that particular specialization.
So I'll also take inputs from Dr. Grace. I think she will have more to add on this.
Uh, Thank you so much, sir. Actually, I know of a couple of fellowship programs in India. So one obviously is from the Tata Memorial, and the second one I know is from the Healthcare Global Enterprise, HCJ Bangalore. Dr. Priyank Tripathi is I think, the director for the clinical pharmacy students who are trying to do the fellowship there. I think it's a 1.5 years to 2 year fellowship there with 6 months of training and 1 year of paid internship. So that is one place that I know that, a center that is offering fellowship program for the pass out clinical pharmacist. And also, I take this opportunity to tell you that we are also in a phase of planning out a fellowship program for hematology and infectious diseases at the Believers Church Medical College Hospital, so that we can streamline these candidates who are interested in these areas, so that they are, armored when they are coming out of this training. They can, straight away go and do what they're supposed to do. So yeah, I think currently what we have right now is the Tata Memorial and the HCG, and soon, hopefully, we'll be having our Believers Fellowship too.
Okay, thank you, Grace. So, from what I understand from the brilliant speakers right now, is the roles are very varied. Like if it is the clinical part of it, education is a very important role that the clinical pharmacist plays. Drug formularies, counseling, patient education, auditing. But what I get from both of the speakers is that research is also very integral to your on your work. I think that is something all those who are listening also should focus on. Like Renita mentioned, find out what is your core interest, and probably that is a good advice to join the center which has your core interest. So, like Dr. Grace just mentioned, so there is an ID focus in a center, and that could also be a hematology and oncology focus in a center. If that is what your career choices are, I think that makes sense to choose the area which excites you most, because that's going to be your life in future. Hmm. Okay, so
There's another hospital that gives out fellowships. There's something called a Shankara Cancer Hospital. So they have this program too. And compared to HCG, the fees, I mean, the academic fees that you have to pay is much cheaper in Shankara Hospital. HCG, I
Great.
guess it's 5 lakh rupees. I'm not exactly sure. And Shankara is 40,000 per year, something around that.
Great. So one of the questions was, what is the future as a CP in India? So I think we've had these three speakers actually kind of give you an idea where you can be if you want to be. So we have Kirti, who's now quite established as her role in as a hematology pharmacist. So she's worked in two centers already, and she's developed a niche for herself. That is one. Second, you can see Anju, who's developing into a transplant. So they're all focusing onto a niche, and beyond this you can see Renita, who's gone on for her oncotherapeutic fellowship. So I think the options and opportunities are growing. Like we are still exploring what are the available options within India, but at least these are very good examples that we have of in the form of our speakers here. So another question that came in was anything particular, what is the focus to study for oncotherapeutic fellowship?
Okay,
Exam,
so
exam.
yes, for the exam, it's an MCQ based exam. So I can speak from my experience. I would say there was a mix of questions from the clinical side. You had it wasn't just oncology; it was complete clinical pharmacology. So there were a lot of statistics based questions. There were a lot of clinical research based questions. There were a lot of dose calculation questions. Again, a lot of clinical pharmacology based questions based on what would be therapeutics questions as well. So I think it's a good idea to refresh these four particular areas. That would be biostatistics, clinical research, I mean, pharmacology principles basically, and therapeutics.
So thank you. I think these were all the questions, and I really appreciate the passion in all of you. I think it must be a joy to work with all of you who are is working with. That should actually rub on to all the participants who've joined in for this evening. Uh, great broad way of looking at the various opportunities available and the roles within even our Indian context. So I have to admit it is still an evolving niche. Many centers are just accepting and growing into the idea of having a specialist niche in clinical pharmacists. But I think the future is now, and we are going to see more of this coming on. And I'll hand over to Dr. Grace for any closing remarks. It was a wonderful session. I loved listening to you. One more thing I just wanted to tell you was there is a feedback that will come to all the participants 24 hours from now. You have to fill it in, and I'm told that you'll get your certificates only after you fill in those feedbacks. Okay. Grace, you have something?
So thank you. I'm sure it was a very high quality webinar for all those who are listening. And without Sepsis's initiative and the whole support that he has been giving to the clinical pharmacy, our clinical pharmacist, this wouldn't have happened. And I'm extremely glad that, to have Kirti, Renita, and Anju, along with Sepsisa, to be the panelists, to be the speakers. I think the choice wouldn't have been any better with any other speakers. So thank you so much for showcasing what all things we can do as clinical pharmacists in India. And I would also take this opportunity to thank all those who have supported us throughout this initiative, our other clinical pharmacists, my coordinator, Dr. Linda, Dr. Marman, and our webinar technical head, Arun Babu. And obviously, and our director, Dr. Jachandi Batitra, for, allowing us to do the things that we want to. With all that, again, just reminding you regarding the feedback for obtaining your certification of participation. Please fill in the feedback that will be sent to your email so that you can get your participation certificate. So thank you. Have a good night. So those who couldn't attend the whole session, the session will be recorded and will be put in the YouTube for your future reference also. So thank you once again. Good night, everyone.
Thank you. Thanks.
Thank you.
Ranita, I had a question for you actually.
Sure.
You put out a slide on posaconazole level monitoring, right? So you mentioned
Yes.
about the 200 mg QID. I thought we moved on to resistant tablets, that is extended release. So I was just commenting on that because they are gastro-resistant, and we have seen in few of the patients that the levels came out to be 12 and 13. So
Right.
toxic effects that we saw in that kind of patients were too much compared to the patients who had level of 3 and 4. So I just wanted to put out that.
I
So,
agree. Yeah.
so you have done any studies on the newer version of POSA?
Not as yet, because what happens is, again, we are a part grant and aid government institute. So we have a particular formulary that is set. So we stick to that formulary, right? But I think we definitely, I would definitely take this and speak about this into practice, and let's see if we can change things around perhaps. Again, it varies from prescriber to prescriber. There would be some who would know of this, and then you would, what we see ultimately is the end result that we observe with the TDM value, and then that is left to our discretion. Then what do we have to do? What is our recommendation based on that? So as you've rightly mentioned, we do see a lot of levels at that end, and that could be attributed to the whole 200 mg QID thing. So yes, I would definitely take that into consideration, and thank you so much for bringing that up. And again, yeah, like I said, it depends from prescriber as well. Even if you have that at the formulary, they would request a patient getting it from outside as well. So it varies again, and that is why TDM comes into picture then for us, because it's kind of important
So
to
it is an
understand.
administration also. It's once a day, and this is QID. Patients have to take it.
It's ease on administration. Yeah, I completely agree. Yeah.
Thank you.
Thank you for that.
Okay, great. Thank you all. Thank you all for the wonderful session. So be safe, and we'll look forward to hearing from you. I'm sure there'll be more sessions in future. Thank you all. All the best.
Thank you,
Thank you
sir.
so much, sir.